Evening. Good evening, everyone. For those of you who don't know me, my name is Jasleen Singh. I am a child and adolescent psychiatry fellow on the IPS Council and part of the IPS Planning Committee. I have the pleasure of moderating tonight's event, providing brief introductions on our wonderful speakers, and moderating the questions at the end. I would like to welcome you all to the second installment of our 2024 virtual series titled The Unified Brain at the Interface of Neurology and Psychiatry. Please keep an eye out for emails with speaker announcements and information on how to register for upcoming sessions on Alzheimer's and traumatic brain injury. Our first session discussed functional neurologic disorders, and the recording of that presentation is available on our website for those who are unable to join us. Before we start tonight's program, I did want to acknowledge our sponsor for tonight's event, PRMS. We do have a rep from PRMS here with us tonight, Rich Stagnato. He's going to speak to us briefly, and then we'll start tonight's program, and I'll introduce our speakers.
Thank you, Doctor. It's great seeing everybody. I saw a lot of you over at the conference in Chicago last year, so it's great to see you here virtually as well. For those who don't know, PRMS is a psychiatry, medical malpractice insurance, and risk management program. It's a program that's designed by psychiatrists to help you with all your needs that you have in your day-to-day practice. We do have information at prms.com, anyone who wants to look at information there. And if you do know colleagues who are interested in malpractice insurance, please feel free to refer them there. If they're referred over to us, whether or not they buy the policy, the referring physician can get donations over to an organization such as yours. Anyone's going to be at the APA annual meeting in New York's. We will be there as well, so be on the lookout for any of our reception invites in the coming weeks and months. So as well, we do have discounts for part-time and early career psychiatrists. Early career discounts go up to the 70-80% range, so there's a lot of good savings as you and your colleagues start your career. So again, it's great seeing everybody, and you have a great panel lined up, so it should be exciting. Enjoy the talks, everybody. Take care.
Thank you.
Thank you very much. For those who are new to our virtual series, we'll start with presentations from our speakers. If you have questions that come up during the presentation, please feel free to put those in the chat. All questions will be reserved for the Q&A session at the end. I'd also like to note that only the presentation portion of tonight's event will be recorded, and the recording will be stopped as we transition into the Q&A to allow for more open discussion. Without further ado, I'd like to introduce today's presenters, who will be discussing PANDAS. We're very excited to have them join us today and to learn from their expertise. Our first speaker is Dr. Pamela Campbell. Dr. Campbell is an Associate Professor of Psychiatry, Emeritus, with SIU Neuroscience Institute at SIU School of Medicine. She's been with SIU for the last 15 years, and she has been working with patients with PANDAS for nearly 30 years. Dr. Campbell attended St. Louis University for medical school and completed residency in psychiatry at Yale University and fellowship in child and adolescent psychiatry at the Yale Child Study Center, and she's board certified in both. She has also been on faculty at the University of Colorado, George Washington University, and University of Cincinnati over her career, and she's a native of Central Illinois. Of particular note, she has also been on the PANDAS Advisory Council for the Illinois Department of Public Health. And tonight, Dr. Campbell is being joined by Dr. Dareen Siri. Dr. Siri serves as an accomplished allergist at the Midwest Allergy Sinus Asthma SC, with locations in Normal and Springfield, Illinois. She is also an assistant professor at SIU School of Medicine. Dr. Siri received her medical degree from the University of California, San Diego School of Medicine in La Jolla, and after earning her medical degree, she moved to Providence, Rhode Island to complete her internship and residency in general internal medicine at Brown University. Then she moved to Florida, where she earned an advanced subspecialty fellowship in allergy immunology from the University of South Florida in Tampa and Johns Hopkins All Children's Hospital in St. Petersburg, Florida. Dr. Siri is a fellow of the American College of Allergy, Asthma, and Immunology, and a diplomat of both the American Board of Allergy and Immunology and the American Board of Internal Medicine. And of note, Dr. Siri presented on the relationship between PANDAS and immunodeficiency at the 2019 Illinois PANDAS-PANS Advisory Council Summit. We're very thankful to have them speak with us tonight, and now I'll turn it over to them.
All right, thank you. Dr. Siri is going to start our presentation, and we're going to be moving back and forth, talking from the psychiatric and the medical perspective through our presentation.
Thank you very much, Dr. Campbell. I'm going to go ahead and share my screen if you just give me a moment. Hopefully you all can see it loading, and here is our presenting screen. Yes, awesome. I see some nodding heads. Just this. So we're going to be jumping back and forth. I'm going to give a quick overview summary, and then we'll take it back to Dr. Campbell for the meat of the presentation, and then we'll bounce it back to me for maybe some opinions on some treatment as well. And then bounce it back to her. So this is PANDAS and PANS for the mental health clinician. I am, again, an assistant professor at the Department of Otolaryngology and Head and Neck Surgery. Hopefully you can hear me well. I have a little bit of background noise. My affiliations and disclosures, I'm the CEO of Midwest Allergy, Sinus, Asthma, Food Allergy Center, and Sneeze, Wheeze, and Itch Associates Clinical Research Center. I'm a part-time chief medical officer for Novir Therapeutics, and I'm an advisor and speaker for Edma Biologics and so forth. I also get some research support. I have been a member and chair of the State of Illinois PANDAS Advisory Council. Currently, that is inactive. There's no financial support for this talk. Oh, my goodness. I apologize for that. That was a sticky finger. And then certainly we will be discussing some off-label treatments. All right. Whew. So definitions, PANDAS, pediatric autoimmune neuropsychiatric disorders associated with Streptococcus. Really Streptococcus, the kind that causes group A strep pharyngitis, and then PANS as definition, pediatric acute onset neuropsychiatric syndrome, which you guys are familiar with. In terms of the assessment, recognizing the signs and symptoms of PANS PANDAS, the etiology, we'll talk about diagnostic aids, a differential diagnosis, and then of course go into expansive information from Dr. Campbell's side, and then we'll round out with some treatment. In terms of the diagnosis of PANDAS, these are the core pillars, which is the presence of either obsessive compulsive disorder and or tic. Usually a pediatric onset, typically for many, many children, it is somewhere between the ages of 4 and before puberty or pre-pubertal. Have we had patients that have presented older? Sure, but this is the bulk of the patients. Of course, that group A beta hemolytic streptococcus involved, of course, in the title of the diagnosis. And then typically there's an episodic course. There may be waxing and waning. There's a sudden dramatic onset. So this is like the child who all of a sudden overnight has OCD. It was previously at baseline and then maybe had presented with some tics after maybe an illness, and certainly temporally associated with that infection, maybe within days. In some subacute courses, it may be a couple of weeks, but most of the time it's fairly obvious. And of course, some neurological abnormalities. Dr. Campbell will go into this a little bit more detail, but clinical features being OCD eating disorder, which can manifest as an eating disorder, or tics. So these are the foundational information, and certainly they can be time-consuming, embarrassing, causing guilt and anxiety, interferes with normal function, recurrent, and can be unwanted and certainly unenjoyable. Additionally, 2 or more of the following may also occur: somatic symptoms, such as sleep problems, urinary problems, things that are new, where they used to be sleeping well and not have problems with urinary issues, and now they're wetting their bed, etc. A personality change, which may be impulsivity. They may try to elope. They are certainly defiant. They don't want to go anywhere. They can be agoraphobic, irritable, easily aggressive, and those kind of things. A mood disorder, such as severe anxiety, separation anxiety, depression, emotional liability. Some psychosis has been seen. Hallucinations have been seen, and certainly some regression, whether that's emotional, motor regression in terms of loss of milestones, particularly handwriting change or poor school performance. So PANDAS is, of course, a subset of PANS. There is the acute PANDAS there you see on that side with the PANDAS, which is group A, beta hemolytic strep associated. There may be some other pathogens that cause some kind of encephalitis type picture, including bacteria, viruses, and other pathogens. And certainly there may be other things that cause a similar syndrome, which could be metabolic, immune, environmental, other genetic factors. And of course, with PANS being variable, it could be the triggers may be variable, the onset may be more subacute rather than acute, duration, and this is a little bit harder in terms of diagnosis. So as we see here from the PANDAS, it is a diagnosis right now of exclusion, mainly because it can be so variable. You can see that some of the essential features are, of course, neurologic symptoms, psychiatric symptoms, immunological abnormalities may be associated, such as immune deficiency, autoimmune or inflammatory diseases. There is a component of social dysfunction, of course, and then infection triggers. The variable timing and variable onset, as well as variable age, can make recognition a little bit more difficult in the PANDAS case. And here are the key differences. The onset may occur in younger or older children, and sometimes even adults, up to 20% over the age of 12. The onset may not be abrupt. It may occur gradually over months and years. The course may not wax and wane, but may be persistent since the time of onset. There may be other concomitant health issues, and certainly may not correlate with any blood work associated with, for example, group A strep infections, such as the anti-streptolysin O titer or the anti-DNase B titer. So not necessarily a blood test that may be associated with that. And there may be some choreiform or stereotype movements, but there may not be, and a tic disorder may or may not be absent as well. So quickly with the etiology, and then I'll transfer it back to Dr. Campbell. The group A beta hemolytic strep, also known as strep throat. This has been associated with pharyngitis. There is a very classic feature there, as you can see. Typically, we think about these: high fever, throat pain, cough, etc. And it is a little bit more difficult to recognize these days. And I think that's why this has led to some of the onset or increased understanding of these kids with PANDAS, because many of the allergy medications that we take suppress some of these symptoms. The kids may not have a fever. The kids may not have excessively a sore throat. We may not think of that. Some of the medications are really quite good at masking some of those symptoms. Of course, at acute onset, sure, we have that, but some of the medications may temper some of those symptoms. It may not be as super obvious. Perhaps the child may be tired. We may not even know. And I know this because I see these kids in my clinic, and they look like they have strep throat, but they came in for their allergies. Their nose was stuffed, their nose was runny. And then indeed, they actually had strep. And certainly some of those could have been a carrier, but some of these are definitely acute. So because medications are so good these days, there can be a lack of recognition. In addition to that, we're seeing a lot of treatment through priority cares and prompt cares. And sometimes people empirically treat. They think that maybe the patient has a sinus infection, and we know some of those antibiotics are not enough to treat strep throat. It is simply not high enough, long enough. And so then we get subclinical symptoms and kind of a partial treatment, and then the kids go on to have group A beta hemolytic strep complications. Of course, we know that this bacteria may cause other problems, such as impetigo and scarlet fever and a host of other disorders. We think that the etiology comes from molecular mimicry. There's a susceptible host, they get a strep infection, there's some kind of an immune dysregulation or hyperinflammatory response. You get abnormal antibody development to neuronal structures, and certainly then we get neurological complications that present as PANDAS or PANS. And this is borrowed from synonyms chorea, some cross-reactive antibodies, specifically in synonyms chorea. This affects the basal ganglia and other striatal structures, and certainly then can lead to symptoms. So the take home for this, group A beta hemolytic strep, we have abrupt onset. This usually is in pediatric, the bulk of the pediatric between the ages of 4 and maybe 12 or 13, leads to PANDAS. And then there's PANS, of course, which is a little bit harder to define in terms of some of those features. But then there can be OCD, tics, neurological signs, and then PANS, a little bit more vague in terms of mood disorder, regression, other variability, personality change, somatic symptoms, and this ending up to be similar in terms of symptoms. So now I'm going to, the key points. Neuropsychiatric symptoms are thought to reflect an aberrant autoimmune or inflammatory response that may be selectively disrupt basal ganglia function. And so now I'm going to go ahead and transition back to Dr. Campbell for the meat of the presentation in terms of the diagnosis and such. So let me stop sharing.
All right. I'll see if I can get mine to share. Oh, and it's hiding my slideshow. There we go. Okay, is everybody seeing that? Okay.
Yep.
All right, so thank you for the introduction, Dr. Singh. I have no financial disclosures. I was a member of the advisory committee, but it was a voluntary committee. And some of the treatments we're going to be discussing will not be FDA approved, and I'll try to mention those as we go by. The role that I see for healthcare providers includes 5 major roles. I'm going to talk about the first one, and then we're going to switch back to Dr. Siri for a little bit to talk about treatment from a medical side, and then I'll come back and talk about the management of these different issues. The initial diagnosis, management of behavioral symptoms, facilitate the treatment of the underlying disorder, helping with the school functioning, and insurance approvals. So we have a role in each of these 5 areas. For the initial diagnosis, many times the presentation may be to a mental health provider, since OCD, eating disorders, and behavioral changes are frequently the initial presentation. So mental health providers have to have a high index of suspicion for the sudden onset. And this is like overnight. I mean, a kid goes to bed fine, wakes up the next morning. They can't get ready for school because they're having so many rituals. You know, these sudden behavioral changes that seem to come out of nowhere. A lot of times when you start exploring the timeline, you'll find out that there has been either an illness in the family, if it wasn't picked up in the child. There's been an outbreak of strep in their class at school. You know, that's within a week or so of the onset of these symptoms. Sometimes if they already have some of these symptoms, there can be a marked exacerbation of it that seems to also come out of nowhere. But you have to have that index of suspicion to include it on your differential if you're going to be able to pick it up. You also have to be able to sort through with the family. A lot of times when you first start talking with them, they won't remember that there had been any illness because they're very preoccupied with these very strange symptoms their child is having. And it's only after you've been processing for a while that they'll remember that there had been something that had occurred previously. So with the onset of OCD, anxiety symptoms, and tics, again, it's a very abrupt, dramatic onset of these behaviors. Usually in prepubertal kids, we do see these disorders starting to present, but they usually are much more gradual. You know, like a child developing tics, you know, it's the same age range that we would expect to be seeing the strep infections. But, you know, usually it starts off with some mild eye blinking or, you know, some mild, barely noticeable symptoms, and gradually progresses, as opposed to waking up one morning and having complex vocal and motor tics that are very obvious and very impairing. One of the things that has become characteristic is the sudden onset of separation anxiety and school refusal. That was one that I have found helpful in children that have not previously had separation anxiety. And then suddenly, I had one boy that mom couldn't go to the bathroom by herself. He would stand outside the bathroom waiting for her. A lot of times they'll start just suddenly refusing to go to school related to this separation anxiety. Again, a child who's not previously had issues. Or they may have had, you know, some normal separation anxiety when they were younger and it had resolved, and suddenly a very intense onset of it. And you have to screen for psychosocial triggers. You know, anything that's trauma, moves, changes in the household. I had one young man who had not had any previous history of school refusal and separation anxiety, but refused to go back to school starting 5th grade. You know, at the beginning of the school year, he just refused to go. And as noted, this was unusual behavior, but it turned out his father had died during the summer. And so we had a major psychosocial trigger, and his anxiety was related to fears that he was going to lose his mother. So he didn't want to leave her. So you have to be carefully screening for any other triggers that could be related to this. The eating disorders was actually, she commented that I had been working with this for about 30 years. I was in Washington, D.C. when the research group was first describing this, and clients that were in need of hospitalization were admitted to my psychiatric unit for closer monitoring. And eating disorders was not on the radar at that time. And I didn't pick up on that until many years later. And I think I missed a couple of PANDAS cases because I wasn't looking at eating disorders per se. The tendency in the eating disorders tend to be more OCD, less. You can have the classic body image concerns, but it's less prevalent in this group, and it's more often related to fears of contamination, fears of swallowing, choking, or vomiting, or texture issues. And again, these are things that were not there before and just all of a sudden have become full scale. It's not kind of a gradual, I'm having some anxiety about this. It's very impairing and very sudden. I had one girl who would only brush her teeth with a brand new unopened toothbrush because of her fears of contamination. And she had to open the package herself. And she was developing some significant dentition issues because she wouldn't brush her teeth. So that's, to me, the key has always been, once we have a high suspicion of this, that I need to involve the medical professionals, because they're actually the ones that can make the diagnosis. We can have a high suspicion or index of suspicion, but I always turn to my immunologist or the pediatrician to do some of the more medical assessments. So I'm going to switch this back over to Dr. Siri, and she's going to talk a bit about how they would diagnose it. And then we'll come back, I'll come back and talk about the consensus of how we treat these individuals. So let me stop sharing.
Thank you, Dr. Campbell, so much. And I do want to thank Dr. Campbell. I'm grateful to her for her introduction to many and many of her colleagues in the psychiatry world that I've gotten to know in terms of this PANDAS offering and interventions. It was really her who made it quite pivotal, and at least in our local town, for us to be able to treat these patients. So let's talk about intervention. Early diagnosis and, of course, treatment of group A beta hemolytic strep is essential and may prevent the progression of complications and worsening disease. And we've seen this. Perhaps a child was caught early, had strep throat. For whatever reason, the parents were familiar. Maybe the child had very mild symptoms. We aggressively treated Streptococcus pharyngitis, and the patient no longer had progression of symptoms. So I think that we should, when we recognize it, treat it aggressively, and certainly be not afraid to swab the kiddo's throat to make sure they don't have group A beta hemolytic strep. So as we're talking about, of course, treatment, we think about the differential diagnosis of neuropsychiatric disorders, different forms of encephalitis, which may be infectious. And we've seen this as well. People presenting with PANDAS-like symptoms or PANS, having actually evidence of infection that's typically done by titers and, of course, a lumbar puncture. Other autoimmune diseases, perhaps basal ganglia encephalitis, which is that is under that PANDAS diagnosis, as well as Sydenham's chorea, which is a subset. Lupus, antiphospholipid antibody syndrome, other forms of cerebritis, severe, for example, thyroid disorder, other metabolic disorders such as Wilson's disease and CNS vasculitis are just some of the differential. And then as far as investigations, is there a single unifying blood test or something like that that will tell us that the child has something like PANDAS or PANS? And unfortunately, no. It has to be a clinical diagnosis along with clinical suspicion, as Dr. Campbell discussed, and then, of course, maybe some supporting information. So we will do a throat swab and rapid culture, rapid swab and then throat culture, and then, of course, rule out other diseases depending on the manifestations and how the patient presents. Consider the differential diagnosis. Do a blood test, perhaps for that anti-streptolysin O titer, or the anti-DNase B titer. They may be helpful. And certainly, depending on the treatment and the patient, some of those actually may be even low, or sometimes they may persist for a long time and be quite high. But typically, we can start seeing elevated titers within days, but usually at the very peak, usually at about 10 days past infection. So that is helpful for us. So in terms of our diagnostic evaluation, we'll check for infection as we talked about, do some blood work, see evidence of other infections perhaps. We often, in my clinic, because I found so many of them, because I think, why are these kids susceptible versus other people's kids? Why am I seeing this subset of patients? We'll actually do a pretty aggressive immune deficiency workup to see if we can find a reason. And of the hundreds of patients I've seen, it has been surprising how many I find that actually have an immune deficiency and then go on to develop other infections and other complications, and then they continue to need replacement or treatment, their immune deficiency. So quite a lot of them. We'll do a autoimmunity workup. We see a lot of these kids as well, presenting as PANS, PANDAS. Perhaps the strep throat is triggering it, but then they really have evidence of other things that are lupus-like, et cetera. And then evaluating for other underlying diseases, other endocrine metabolic diseases and other comorbidities. Genetic testing has also been really helpful. So between a combination of perhaps blood urine tests, there's some other special tests that can be done. And certainly neuronal antibodies can be done as well to look for other forms of encephalopathy or autoimmune encephalopathies. We may do cultures, we may do imaging, such as MRIs, and then look at the other differential diagnosis and think, are there other things problematic, especially in the immune deficient patient who may need a sinus CT or a chest x-ray, EEG or sleep testing, which may be helpful to make sure that these are not seizures, and lumbar puncture if we can get one. If we can find a neurologist who's quite interested, then perhaps we can look for evidence of infection, inflammation, et cetera, autoimmune disease. And it would be individualized to do additional testing, especially if there are many medications that may be involved. So as I embark on medical treatment here, I'll run through this real quick. We have the PANS treatment, which is antimicrobial, immunomodulatory, or psychotherapeutic, which are the three arms. So the general treatment principles here, we establish a diagnosis, which maybe for PANS is diagnosis of exclusion. For PANDAS is a little bit better in terms of those principal symptoms. And then we will provide symptomatic relief, which Dr. Campbell will go into in terms of psychiatric medications, behavioral interventions, of course. And then treating underlying infection if possible, which may mean removing triggers and removing colonization, because certainly people can be colonized with dysbiosis and have, of course, a bacteria that is there all the time, reminding their immune system that there's a problem, which is when we consider the use of therapeutic, short-term, longer-term, and even prophylactic antibiotics, particularly if they have recurrent infections. We'll treat symptoms resulting from the neuroinflammation with anti-inflammatories. And then beyond that, if simple anti-inflammatories do not work, or perhaps they do work, but then they're short-term, then we'll use more immunomodulatory treatments. And then we have to constantly evaluate the effectiveness of this and modify the treatment regimen at frequent intervals, hopefully until we get to remission. But certainly this can be relapsing and remitting. And sometimes people are in remission for some time, and then they get another trigger. Most often we see a strep throat trigger, even after tonsillectomy and such. And the patients will have some recurrence of symptoms. And of course, we're talking about now antimicrobial treatments, acute antibiotic therapy. For me and my protocol is typically up to 30 days for the initial trial to see how that's going. A penicillin-based antibiotic is preferred, but certainly we may try other ones such as macrolides, clindamycin, doxycycline, et cetera. Prophylactic therapy, we individualize depending on the patient. frequency of infection, whether or not they've had tonsillectomy, the response to antibiotic therapy, and then we will try to decolonize our very best with bleach baths, mupirocin, Hibiclens, and all the other things that we think about, especially if they have issues with perianal colonization. And we cannot underscore how important it is to screen contacts such as siblings or even parents. Most of the time it's a sibling that is colonized and causing problems, triggering these children as well. So the immunomodulatory treatments may include, of course, nonsteroidals. We, of course, have to GI prophylaxis and make sure that they take it with food so they don't have problems with that, because we certainly don't want these medications causing side effects. Corticosteroids, I usually make sure that the kids have a good immune system, or at least it's not going to be damaging to them before I start corticosteroids, and I'll bridge it with antibiotics if necessary. And then we do empiric trials of this. We'll screen for primary immune deficiency, of course, prior to starting. And then for some kids, they may require higher doses, particularly if they have a lot of evidence of autoimmunity. IVIG is something that has been foundational for the allergist immunologist in terms of using it, either for replacement for those with immune deficiency, or certainly in acute higher doses for the treatment of PANDAS specifically. And then perhaps some immunomodulators long-term, if we can get those. And then plasmapheresis has a role as well in pulling off some of those auto IgG or auto antibodies. So diagnostic challenges with PANDAS being recognized, newly described in the past decade. There have been challenges in our local community, educating other providers. I don't have to educate psychiatrists. Psychiatrists know, but the other providers a little bit resistant, especially in this region, of understanding, knowing about the disease. And certainly there's been a lot of immune dysregulation, a lot of allergy, autoimmunity, cancer, et cetera, all those immune diseases we're thinking about in the past 20 to 30 years. So this problem is certainly growing. There's been a dire need for doctors, providers, just like you guys, to recognize, refer, and engage in those patients to get them treatment. And so certainly it has been a pleasure and privilege to work with Dr. Campbell and her team to look for these patients. So the next step, besides having a high index of suspicion, thinking about all of those things associated, such as OCD, mood disorder, neurological signs, tics, all kind of coming together, but again, they can occur separately, seeking evidence for strep or other triggering infection, talking about them, doing that rapid strep or throat culture, documenting that this is a possible diagnosis with patients and families so they can educate themselves and perhaps educate their pediatrician if their pediatrician is not already knowledgeable, and then perhaps referring back, as Dr. Campbell does, to the pediatrician or to a specialist. So that is my part, and I'm going to turn it back to Dr. Campbell to round out the discussion.
All right. What I'm going to be speaking to next is based on the consensus guidelines. These were based on primarily on clinician experience from a multi-site meeting. I mean, it was a collection of some of the leading researchers across the United States. They had this meeting, I don't know if it was 2016 or 2017, but the papers came out. There's 3 papers that came out. The first one covered most of the psychiatric and behavioral interventions. And then there's ones on immunology and overall treatment. This is the major, it's the Bible that we use for treatment at this point. So I'm trying to get my slide out here so I can see the whole thing, and it's not cooperating with me. Okay. So the treatment from the psychiatric perspective really depends on the presentation. It varies depending on what type of symptoms they are presenting. It has to be individualized. Each child is different, so there's no one intervention that works for all. And the primary focus is on the safety and functional ability of the child. As far as psychiatric treatment, there's very few controlled studies. A lot of the focus and research has been on trying to identify the medical aspects of it. How is it happening? How do we diagnose it? Can we get that diagnostic test that's going to give us the answer? There are no pharmacologic studies that I could find. There was one pilot from 2015, which was a multi-site study, but again, it only had 11 patients in it. They were looking at cognitive behavioral therapy. It was open label. As noted, 8 completed with significant improvements in their OCD symptoms and had a remission of 6 of the 8 at the follow-up, which was 1 to 4 months later. The other one was a controlled study of CBT in 7 use. Again, very small numbers. 6 of those 7 were also on SSRIs. Improvements were noted in all immediately post-treatment, but only 3 of the 6 were completely in remission at 3 to 6 months. That's the extent of the psych studies that have been done. But we had a lot of very skilled clinicians that were weighing in on how to try to help these individuals. The data does show that cognitive behavioral therapies can be effective in this population. I still maintain that you have to be treating the underlying medical issue in conjunction with this. Otherwise, you are not going to make a lot of progress. Parents need a lot of support with this as well. This is a very strange change in their child. Many are not prepared on how to deal with this. And it's a fine line to walk with not pushing your child too hard, but also not pulling them completely out of functioning. You get some parents that don't want to stress their child at all. We've got others that are trying to keep them in school and keep them performing academically. So we have to work with them, and particularly on how to try to guide people out of a compulsive behavior, how to minimize tics, how to manage their separation anxiety. So parent management is an important component of this, and also helping the parents to understand, that their child is not doing this for attention, that it is a real medical issue, that the child does not have control. The recommendation is that we can use the SSRIs for OCD, but that is based on studies of individuals that do not have PANDAS. And fluoxetine and fluvoxamine and sertraline are the only ones that are FDA approved for OCD. That doesn't mean that the others can't be effective. I have some qualms on using fluoxetine in particular because it is a strong 2D6 inhibitor, and it can interfere with some of the medical treatments that are being applied. On the other hand, weight gain is a common side effect with these meds, and due to inactivity, weight gain can become problematic during a PANDAS flare. And particularly if they're on steroids, that becomes problematic. So there's a lot of things to consider in making that selection. And we have data on effectiveness of all of the SSRIs in OCD, but those 3 are the only ones that have the FDA approval. We have found that they can be very prone to side effects with the SSRIs, particularly with activation. I start very low. I have one young lady who's actually been doing very well, but we've never gotten above 20 milligrams with sertraline with her. She tends to get activated at anything higher than that. And I have found at times that the activation can occur with one SSRI, but if you try a different one, many times it will be better tolerated. In more extreme cases, I do have a case of one I missed, I believe, but very acute onset, again, an overnight type of onset of psychotic symptoms. She was quite paranoid, very disorganized. She came into the hospital very disheveled. In cases like that, antipsychotics may be more effective. I found for extreme OCD that sometimes we need antipsychotics to help supplement. That is not, again, something that is not FDA approved. Same for short-term interventions. Sometimes we need some PRNs to help with a variety of things. Visceral, hydroxyzine, sorry, or I'm forgetting the generic for Benadryl, gabapentin, benzos, clonidine have all been shown to be helpful with various issues with sleep, with anxiety. They can be useful on short-term basis to help during acute phases. For tic disorders, again, the onset is usually sudden, frequently Tourette-like with both complex motor and vocal tics. The recommended interventions are the comprehensive behavioral interventions, habit reversal training. Pharmacologically, the alpha-2 agonists can be very helpful. The consensus questions the efficacy with the alpha-2 agonists if they don't have ADHD as well, but I've still found the alpha-2 agonists to be helpful with tics. And in the more severe cases, the antipsychotics can be very effective for particularly the complex and vocal tics. Okay, so the goals of our interventions are to reduce suffering, improve their functioning, and increase their ability to participate in necessary treatments. I have a young lady who has a lot of compulsions and obsessions around toileting, and she will only use the bathroom at home. And the place that she was supposed to get her IVIG, she wouldn't use the bathroom there and was several hours away. And that was very problematic because she can't hold it that long to get through the treatment, which can take several hours to complete an IVIG treatment and do the transportation back and forth without having to make a bathroom stop. So getting her to the point where she could leave the house and use a bathroom somewhere else was essential for getting her, or we actually eventually had to facilitate getting her home-based IVIG because it took too long to get her able to function in bathrooms outside the home. For irritability and aggression, which I see more often in boys than I see in girls, although the girls can certainly have these issues, but there's a series of approaches that we use, the environmental interventions being some of the key ones. A lot of times they're more easily overstimulated. So modulating the stimulation, minimizing demands, a lot of times can be very helpful because they're trying very hard to do the things that they're used to doing and they're finding it very difficult to do. Need to ensure adequate sleep and nutrition and use distraction. A lot of times when they're starting into a meltdown, if you can distract them, you can redirect them away from it. Pharmacology, again, is not FDA approved, but benzodiazepines can be used for anxiety-related, and antipsychotics and mood stabilizers are recommended for mood swings and irritability. For delirium-based agitation, because this is basically an autoimmune encephalitis, there are recommendations for the diphenhydramine, thank you for Benadryl, benzodiazepines, and antipsychotics. Okay, you need to be assessing for underlying causes. If there is for the ADHD, I'm sorry, if their behaviors are consistent with ADHD, methylphenidate is recommended over the amphetamine salts because they're a little bit less likely to exacerbate tics or compulsive behaviors. And the alpha-2 agonists, I think, are most people's first line because they can also help with tics, they can help with anxiety, they can help with sleep. Stimulants particularly can increase some of the irritabilities. They're shorter acting many times. So a lot of times I'll go with the alpha-2s first before I'll try stimulants unless they already have a history of ADHD. Okay, for sleep issues, many of them start having difficulties with sleep. So first, of course, all of us are now frequently addressing sleep hygiene with our teenagers in particular. They need a regular bedtime, comfortable environment, winding down from stimulation. Don't get stimulating activities in the evenings, restriction of the electronic games and TV for an hour before bedtime if possible. There's no FDA approved treatments for sleep issues, but antihistamines, melatonin, cyproheptadine, clonidine, and trazodone all have anecdotal reports for efficacy. One of our key functions is to facilitate getting the treatment of that underlying disorder. For complete remission, treatment of the underlying disorder is required. So if I'm suspicious, first thing I do is get on my phone to Dr. Siri. It's like, how soon can you work this one in to get that medical intervention started? I'll start what I'm going to be doing for the OCD, tics, anxiety, but we've got to start treating that underlying treatment. All right, for school difficulties, the things that we encounter are very frequently what we see with other types of encephalitis, attention problems, handwriting difficulties. You can actually identify flares in the disorder by changes in handwriting. It can be very striking how extreme the difficulties with handwriting can become. They have difficulty making it through a full day in school. They have particular difficulties in math and processing speed, memory issues, and they're going to have frequent absences for medical appointments and when they can't get out of bed or they can't get dressed because they're tied up in their rituals, or they're self-conscious because their tics are prominent and they're embarrassed to be in school. So we help by helping to excuse reasonable school absences. Sometimes you have to try to encourage them to make the attempt to go to school. IEPs and 504s can be developed to reduce workload, accommodating for separation anxiety. Maybe they can call home once a day if they're feeling anxious. Work on alternative methods of doing schoolwork if the OCD symptoms are interfering. If they can't complete their assignments because they have to be perfect and they keep doing it over and over again, doing some alternative presentations for them. One of the things that is key to me, something you don't see usually in OCD or anxiety, is the urinary frequency. That's always a red flag, and I screened for that in my initial evaluation. And so they need to have permission to be able to go more frequently to the bathroom. You'll get a teacher or someplace that says, you're only allowed, to do that once a week or something, and they might need to do that several times a day. If they have dysgraphia, using note takers, ability to dictate or type their work, and accommodate the math difficulties with the calculator or using resource support. Finally, the battle with the insurance coverage. We have a role in this as well. A lot of these treatments are expensive and they're resisted. That's one of the things we did on the advisory committee was fight with the insurance companies on the stepwise interventions. sometimes they try to require prior interventions such as CBT or SSRIs before they will authorize the IVG. And this came down to a really ethical issue for me, because the insurance was insisting that this patient that had no OCD or anxiety symptoms had to have a trial of an SSRI before he could receive IVIG. He was having primarily irritability and aggression. And I didn't feel it was ethical to treat him with an SSRI when that wasn't the appropriate intervention. But, the insurance was inflexible. This is what had to happen in order for him to get his treatment. So we wrote many letters on trying to get this child the services that he needed. My go-tos for treatment is the PANDAS Physician Network. If you just Google it, it's a wonderful website that has treatments, diagnosis and treatment recommendations for both mental health providers and the medical teams, and also the consensus guidelines, which was published in 2017 and is listed, the fourth one down on my bibliography. Those are my Bibles for working with this population. So that's the rest of my talk. I think we're ready at this point to open up for questions. I know you all recognize the one panda, but the other one is what's called a red panda, which I think is, they're not as roly-poly as the black and white pandas, but I think they're equally cute myself. All right, questions?
Thank you for the wonderful presentation. We'll go on and stop recording so we can transition to the Q&A portion.